comparative study of the SMILE with 5 millimeter versus 6.5 millimeter optical zone for myopia. Dr. Ladis, please.
Respected dignitaries on the dais and friends. Comparative study of small incision lenticle extraction with 5 millimeter versus 6.5 millimeter optic zone for myopia. Ectasia possible after any corneal refractive laser. Only predicting factor is residual stomal thickness. Reducing optic zone increases RST. Hence, optic zone was reduced to 5 millimeter and parameters were compared to 6.5 millimeter. It's a retrospective comparative case series. Inclusion criteria were stable myopia more than 18 years, willing for minimum 6 months of follow-up. Exclusion criteria, vision less than 6/36, abnormal topography, corneal opacities, and retinopathy. Ethics committee approval was taken. Informed consent was taken from all patients. Period of study is 2016 to 2021. It's a study of 690 eyes of 345 patients. Apart from routine testings, preoperatively for the refraction or refractive surgery, contrast sensitivity, scotopic pupil size, aberrometry was done pre-op, and post-op was added glare and halus testing. Group analysis was done by the Innova and Kruskal-Wallis test. Difference in categorical group were by Chi-square test and Fisher's exact test. Data was entered into 12.2 strata. All p-values less than 0.05 were considered statistically significant. Results, apart from routine variables, pupil size was 3.7 in both the groups on an average, and lenticle thickness was significantly low in 5 millimeter group with p-value of less than 0.001. Unaided visual acuity, glare and halos and contrast sensitivity was within normal range at post-op day 1 month, 6 months in both the groups. But if you see at the end of 6 months, residual stromal thickness was significantly high in a 5 millimeter group with p-value of less than 0.001. Change in optical aberration at the end of 1 in both the groups were not statistically significant. When this was compared with the degree of myopia, apart from routine parameters, in a 5 millimeter optic zone, almost 56% were high myopia. On a day 1, in both the groups, glare and halos were noticed more on day 1, which are not seen in the subsequent visit. Residual stromal thickness was significant in both the groups without any changes, and optical aberrations were not much altered in both the groups. This is the 6.5 groups, this is 5 millimeter group, this is the pre-op changes, and this is post-op changes, not showing any significant change by the surgery. When Loew's curve was driven with 690 all eyes, it consistently showed high IST in a 5 millimeter group. 30.6 micron higher RST was achieved in 5 millimeter optic zone compared to 6.5 millimeter group with confidence interval of 95.28 to 33 microns with p-value less than 0.001. Reducing optic zone less than 6.5 millimeter is recommended to increase the RST and improve the biomechanical properties of the cornea. To the best of our knowledge, this is the first study reporting on outcome of SMILE with 5 millimeter optic zone with relatively large sample size. The minimum optic zone used before was 6.2 mm by Queen and et al. When standard 6.5 millimeter zone was reduced to 6.2 millimeter, change in total corneal power 4 millimeter from the center of the pupil led to most accurate target refraction at 1 month. This is what prompted us to use 5 millimeter optic zone. So first you separate and do the anterior dissection, then you do the posterior dissection, and this is what you see, the posterior dissection, and lenticle is removed from the eye. So in conclusion, 5 millimeter optic zone gives excellent refractive correction, gives significantly high residual stromal thickness, improving corneal biomechanical properties significantly, didn't induce greater higher order aberrations, and it was well tolerated by our patients. These are our references. Thank you.
Thank you. It's an excellent presentation. Do you have a nomogram for 5 millimeter?
the nomogram used for both of the 6.5 and 5 millimeter is what was given by the factory. That is, you can say 0.25 millimeter higher treated for the myopia.
I couldn't follow. The lenticle thickness was changed in 5 millimeter.
Correct.
So how much of the change you did? Whether you use a nomogram for that or not?
No, there is no nomogram. Same nomogram which was there for 6.5 was followed for the 5 millimeter group, which was given by the factory. So no change of nomogram was required.
See, if we do the LASIK, we know that if we use a 6.5 millimeter, we use a 6 millimeter. If you use a 5.5 millimeter, the ablation changes. But if we are using the same thickness, whether it will affect or not?
It will not affect, sir.
Reason?
That's what has been shown, that when the study was done by Quinetol and they reduced the optic zone from 6.5 to 6.2, they realized that target refraction was still more accurate compared to 6.5 group. So when they reduced it, it is better. When Titial et al. Did the studies and they showed that when the optic zone is reduced, RST is increased more, so this is still better.
Okay. And what about the higher adoptions you just told?
Yeah,
You
none
couldn't-
of them were significant in both the groups, sir.
Okay. But I have a doubt. I'm not sure about it. Dr. Pooja, can you explain anything about the smile? Dr. Ladi is using 5 millimeter zone and 6.5 millimeter. Will you use the same nomogram or it should be different?
I think the nomogram should be different because that has to be based on larger number of studies. Smaller numbers probably wouldn't.
This is 690 eyes.
I'm just thinking
Have you used 5 millimeter before?
we don't.
So how would you know, sir?
Pupil size also because the mesopic pupil size is also important. I'm sure you've checked that here as well.
Indian average 3.7, ma'am. And rest of the study shows not more than 3.8.
And what was the average duration of follow-up about these cases?
6 months minimum. That was included into the inclusion criteria.
How about the post-surgery glare and shadows?
Only, that's I said, that only in high myopia group on a day 1, in both the groups, glare and halos were noticed more. On week 1, 1 month, 6 months, none of them complained of glare and halos. Why would anybody do, sir, 690 cases with the patient complaint of glare and halos? Vinod, sir,
Yeah, please.
my sincere question to is,
Sure, sir.
my submission to is that why would somebody do to a patient's when if they continue to complain glare and halos and have a higher order ablation, 690 cases, sir.
Okay, that's your study. You can just tell about the
Yeah,
things, right? It's okay. Thank you so much.
Thank you.
Any
Thanks a
question?
lot. Thank you. Thank you.
Dr. Pooja would like to speak first. Okay, Dr. Pooja has to go somewhere, and she is the winner of last year award for this session, and her keynote address will be there. You can use this one. Dr. Pooja won the AIOC Prasad Hardiya oration last time. She's going to speak the same topic. There's the next generation rapid tear diagnostic kit for refractive surgery.
Thank you, sir. At the outset, we do not have any financial disclosures. I'm going to present the same thing. So last year when I presented this paper, we were in the peak of COVID-19 and we were almost recovering from the second wave. So COVID-19 did teach us that, we need to look into the power of rapid diagnosis, the power of immunology, and how to modulate it to have a better patient outcome. The earlier we diagnose it, the better it would be for patients. We do have some knowledge gaps in refractive surgery, like, patients having extremely high post-LASIK discomfort, inflammation or dry disease, neuropathic pain, which is the pain without stain, absolutely normal preoperative evaluation. When we do a refractive surgery, post-surgery, they land up into post-LASIK ectasia, progression in keratoconus, and haze or scarring post-PRK or cross-linking. So we have done a thorough clinical signs and symptoms checkup. We have done a thorough medical history, systemic and dry evaluation, imaging parameters. But still post-refractive surgery, we do come across some complications. What is the missing link here? Why do we need it? We do understand that the molecular markers are involved, and these are the inflammatory cells which are responsible for the poor wound healing, haze, dry eye disease, ectasia, and ocular inflammation, which in this thing might impact the surgical outcomes, response to therapy, and choice of medication, which might be for refractive surgery, keratoconus, cross-linking, dry disease, and many other ocular surgeries which we perform. There are a lot of trials going on potential specific molecular biomarkers in ocular diseases and the potential therapeutics. But the question here is that how do we identify these molecular markers? How do we identify that what is wrong in the patient and what drug the patient will need? So we wanted to know, can we have a point of care diagnostic kit to diagnose these ocular changes? The answer would be, first of all, we need to choose the right markers. So the markers which are commonly involved in the increased discomfort will be IL-17, VEGF-A, MMP9, ICAM-1, KC progression or post-LASIK ectasia, markers involved in post-PRK haze or cross-linking haze, pre-refractive surgery evaluation for ectasia and dry eye, pain without stain, and retinal conditions. So there were some markers which were common across all these conditions. We chose all of them and we decided to build the point of care diagnostic kit, which is ELISA-based fluorescence, a microfluidic device based on the antigen-antibody reaction, where the antibodies are present in this well and the antigens come from the tear of the patient. And this is how the markers are incorporated in the kit. We recruited controls, post-refractive surgery, dry patients, keratoconus, and patients with various other conditions, and subjected them to tear collection with Schirmer's strip and the test. We collected Schirmer's tears using the Schirmer's strip in an Eppendorf tube, and to this Eppendorf tube, 300 microliters of extraction buffer solution was added, and then it was shaken for 5 minutes so that all the inflammatory molecules will go in the tears, and then these tears were put in the cartridge and put in the analyzing system, which is the diagnostic device. At the end of it, we get values for each of these markers, and based on the reference interval, we can decide whether it's normal or abnormal. What we saw was that patients with chronic contact lens use, dry eye, progressive keratoconus, or non-responders to dry eye management had significantly higher levels of IL-6 and IL-8, which is suggestive of inflammation and which requires customized treatment. And this test was also done for glaucoma and retina-related conditions. What we found was that not all the patients had higher levels of VEGF-A, and giving anti-VEGF for these patients was not an appropriate treatment, and they required steroids in this case. Applying it to clinics, it has beyond refractive surgery, it has applications in cataract as well. Patients with chronic itching, discomfort, poor wound healing, glare, halos, poor optical quality, or refractive surprises are because of the subclinical inflammation present in them. And if we know that any of these markers are on the higher side, we can customize the treatment with either using trehalose-based drops, doxycycline, steroids, or modern-day dry eye therapy for each of these markers and have an optimal outcome. The way forward would be that we are working on the retinal conditions like vascular occlusions, diabetic retinopathy, ROP, dopamine levels in tears, and glaucoma conditions as well. And we are also collaborated now with a pharmaceutical company who will help us produce these kits, which will be available after this FDA and the CE mark approval. And this has a role in cancer detection as well. Actually, if the VEGF levels in the tear are higher to begin with, even if the patient is not a known case of a cancer, any type of cancer, you can detect it in the tears before patient knows about it. So point of care diagnostic kit does help us in identify these biomarkers. Tear biomarkers can help us in diagnosing subclinical inflammation, and this is the first panel in the world in eye care with multiple markers to diagnose various ocular conditions. And right now we are working on the regulatory approvals as mentioned. Thank you.
Excellent talk, Dr. Pooja. This MMP9 kit is available, I think.
MMP9 is available, so that's a standalone kit,
Okay.
and that will only tell you if the MMP9 levels are higher or lower. That will not give you a quantification. Anything more than 50,000 is higher, but if the patient has a level of 2 lakh, then only a cyclosporine will not work. So there you need a modern day dry therapy. So that's how this kit will help. And along with MMP9, we have other markers also.
How much the cost is roughly?
This will be produced in India, and the company which we have collaborated it is like Atmanirbhar, so we might have a cost of 1,400 for both the eyes. At this point of time, the Inflamma dry eye kit which is available is 1,400 per eye. This will be both the eyes, and with multi-markers.
That will be affordable.
Yes, and I think a lot of Indian companies are now working on Lifitegrast, so that also will be available soon.
Thank you. Thank you so much.
We have the next speaker now, Dr. Nikhil Balakrishnan. He is going to present on intense regulated pulse light therapy in averting worsening of pre-existing dry eyes following LASIK.
Yeah, go ahead with that.
Dr. Pavitra Patel.
Good afternoon, everyone. So at the outset, none of the authors have any financial interest. I'm Dr. Pavitra Patel Balkrishnan, and the topic for my today's presentation is intense regulated pulse light therapy in averting worsening of pre-existing dry eyes following LASIK. So LASIK is one of the most common procedure which influences the post-operative tear film status, and post-operative, the dry eye affects approximately 50% of the patients at 1 week post-operatively. However, this LASIK-induced dryness is yet manageable. But what about people having dryness pre-operatively and then undergoing LASIK? It is definitely going to worsen the already existing dryness, and it will lead to suboptimal operative outcomes. So literature shows many authors have treated the worsened dry eye symptoms with the IRPL therapy, but that led to me a question that why can't we do it prior to LASIK surgery to prevent worsening of already existing dry eye symptoms? Yeah. So the research question was, can IRPL therapy be used pre-operatively in patients undergoing LASIK surgery suffering from dry eyes to prevent post-operative alleviation of dry eye symptoms? So the aim of my study was to assess the efficacy of IRPL therapy in prevention of worsening of the pre-existing dry eyes post-LASIK. So this was a prospective interventional study which included 50 eyes of 25 patients willing for LASIK surgery. In each patient, the right eye underwent 2 seatings of IRPL therapy prior to LASIK surgery, and the left eye was treated with only warm compressions along with the routine medical management. Now, all the participants provided written informed consent. Inclusion criteria was age more than 18 years, clinical signs and symptoms of MGD, willingness to continue ongoing therapy with unpreserved tear substitutes, and Fitzpatrick skin scale between 1 to 4. The exclusion criteria were any ocular diseases apart from MGD, for example, Sjogren's syndrome, previous IPL, IRPL, or thermal pulsations therapy within the past 24 months, previous ocular surgery or eyelid trauma, punctal plugs, pregnancy and breastfeeding, and any uncontrolled ocular or systemic diseases. So once the patients with dry eye were selected for undergoing LASIK surgery, a stepwise approach was followed. On day 1, to begin with, a clinical and automated assessment was done, followed by first session of IRPL therapy to the right eye and warm compressions to the left eye. Now, after 15 days, second session of IRPL therapy was given to the right eye, and warm compressions were continued for the left eye. After 3 days, bilateral LASIK surgery was done, and routine postoperative medications were given for both the eyes. After 1 month post-LASIK surgery, again, the clinical and automated assessment were repeated. Now, the clinical assessment mainly included Schirmer's test and OSDI questionnaire, which is composed of 12 simple questions. And the automated assessment included evaluation via ocular surface analyzer, which is known as EDRA, which gave us 4 parameters, namely the non-invasive breakup time, lipid layer thickness, meibography, and tear meniscus height. Now, NIBT is the time elapsed from the last blink to appearance of the first random break on the ocular surface. Normally should be more than 20 seconds. Next is the lipid layer thickness, which gives us or which detects the colored lipids on the patient's eye and should be between 60 to 99. Next parameter was meibography, which basically gives us direct visualization of the morphology of the meibomian glands. And the last parameter was the tear meniscus height, which should be between 0.1 to 0.5 mm. So what was the treatment protocol like? IRPL treatment was given using a EI device. Patients received 2 treatment sessions performed at day 1 and day 15 in the right eye, following which the patient underwent LASIK surgery for both the eyes. Treatment intensity was determined based on the Fitzpatrick skin scale. 5 flashes were applied only on the right eye, starting from the inner canthus to the temporal region of below the lower eyelid. So what were the results? 14 out of the 25 patients were female and 11 were male. The average Shermer score increased to 26 in the right eye and 18 in the left eye respectively. But when we compare the right and left eye, the improvement was significant only in the right eye. There was no statistical significance noted in the OSDI between the two groups because 7 of the 12 questions in the OSDI questionnaire required binocular function, and hence scores for both the groups for these questions were identical. Again, there was a significant improvement in the Niebert score, but when we compare in between the two eyes, it was significant only for the right eye. Again, the percentage of change in the gland loss post-LASIK surgery for both the eyes was not significant. The lipid layer thickness showed significant improvement in the right eye when compared to the left eye. And there was no significant change noted in the tear meniscus height for both the eyes. Now we achieved 6.6 in all 25 patients at 1 month post-LASIK. And there was no immediate DLK noted in the right eye. However, 2 left eyes developed DLK in the immediate postoperative period. Now, there are various clinical studies about the use of IRPL treatment. So, in our study, patients showed significant improvement in both the eyes for Niebert, lipid layer as well as subjective. However, it was significant only in the right eye. And the parameters which didn't show any improvement was meibomian gland loss and tear film height. So what was known was IRPL has good outcomes in MGD-related dry eyes, and LASIK surgery causes increased dryness. So what new does this study add? It is one of its kind to use IRPL therapy in dry eye patients prior to LASIK. It compares the efficacy of IRPL therapy versus warm compressions in contralateral eyes. It emphasizes that a healthy ocular surface prior to LASIK leads to optimal visual outcomes and alleviates the dry eye symptoms. Thank you.
Excellent. Can I ask you a question?
Yeah.
Which were the patients which you labeled as dry eye, where you did the IRPL therapy?
Based on the clinical and the automated assessment.
Yeah, so
basically.
what was
So
the T-bar
for example,
cutoff?
Shermer's, the cutoff was less than 10. We included all mild, moderate. It was not
Yes.
particularly only for the severe category. So it was a combined category, but basically they were diagnosed as dry eye. So Shermer's less than 10, on OSDI score of less than 15, and an automated assessment, again, Niebert values of less than 20, because more than 20 was the cutoff for Niebert. So accordingly, whatever cutoffs were, whatever we had given the cutoff value, anything less than that, we had.
But if it's a patient who is very severe, you would not do LASIK anyways, right?
No,
So-
that is why the therapy, that is why the role of therapy, that we
No,
gave
what-
IRP.
Yeah, there would be
how-
some subset of patients where you would not do LASIK. I mean, and even for the other eye, where you have not done the IRPL therapy.
Yeah, so that was a contralateral study, so obviously.
Another thing is, how does it differentiate from giving the treatment pre-operative and giving it post-operative?
reduce-
Identifying the things and do it post-operative.
Basically, pre-operatively, if we already know that the patient is a dry eye patient and patient is willing
See,
for.
that we already know,
Yeah,
post-LASIK
yeah.
patient is going to suffer from dry eyes.
Yeah, but
That doesn't mean we stop treatment for that, no?
No. Medical management was there for both the eyes, so pre-operatively and post-operatively. But in addition to that, we gave IRPL sitting in one of the eyes to see pre-operatively, to see how they are improving post-operatively. By giving that extra IRPL therapy, what was the improvement like?
What is the usual schedule? 3 sittings are usually
sittings,
required.
that's
So
all,
here we
yeah.
have done only
Only
2.
two
And did you
sittings.
do the third one post LASIK or no?
We did not do, no.
And the effects are usually seen 4 to 8 weeks later.
Yeah,
so
we
here
had,
now
4
4
months,
weeks. So
yeah, 4
maybe
weeks.
after one
Yeah,
more
yeah.
month, maybe the results would be a little
Maybe
different.
yeah.
Or maybe they achieve the same state.
Maybe. So we need to have a little long term. So you should see at 4 weeks as well as for 8 weeks. And with a complete therapy, there's no hurry to go in for surgery.
Yeah.
So maybe you could have completed all the 3 sittings to give them the best results.
Correct.
Thank you.
Thank you.
Pooja, I think we'll allow her to continue with her talk also. She has to.
Thank you for allowing me to present. I'm going to be presenting an algorithmic approach in management of unhappy patients post-refractive surgery. At the outset, we have no financial disclosures in this study. So these are the 2 types of patients who have undergone refractive surgery. Post-surgery, the quantity of vision is good in the first patient, but the quality is poor. Well-centered topography, epithelial mapping is regular, but poor quality of vision, and DLI is 7.82, which is within normal limits. No evidence of dry eye. Here also patient complains of blurring of vision with this refractive error, but rest all is within normal limits. So why is the patient still unhappy after refractive surgery? Can we devise an algorithm to manage unhappy patients after refractive surgery? So what we did was we conducted a study where in past 1 year 4,000 patients were operated. It is a prospective interventional study, and we included patients with blurred vision, difficulty in night driving, asthenopic symptoms, glare and halos, and exclusion criteria were any retinal conditions or change in axial length. Out of 4,000 surgeries done, 65 patients were unhappy. We did a thorough history taking, visual acuity, dry eye workup, a stepwise approach, tomography, aberrations, contact lens trial, non-strabismus, binocular vision anomalies, and lenticular changes. So if the patients had the glare, halos, or difficulty in vision, in the workup, first they underwent detailed history, surgical history, and detailed vision assessment. And the first one was to rule out the dry eye. We found that in our cohort, 22 patients had dry eye, which was found after doing meibography, Schirmer's test, and tear film breakup time. And they were treated accordingly for the dry eye. Post-dry eye treatment, this is the visual breakup time and the OSI, which is poor. In the patients who had dry eye, and post-surgery, post-treatment when they were treated with dry eye, their optical quality improved, their OSI improved, and the VBUT also improved. So these were the patients who showed improvement, and remaining 6 patients needed intense pulse light therapy based on procedural therapy along with medical therapy. The patients who did not have any dry eye, the patients who were normal were given, they underwent a corneal tomography and a contact lens trial because 3 of them had decentered ablation. Of this 3 patients who had decentered ablations, when they were given a contact lens trial, there was improvement in symptoms. But if there was no improvement in the symptoms, we assessed the lens status. If the lens status was checked with the dysfunctional lens index or the PNS in the pentacam. We found that 5 patients had a poor dysfunctional lens index, and if they had a poor lens functional lens index, that means they were higher order aberration. It's a very early cataract, which is also known as Zernicke's cataract, and for them we decided to not do a repeat surgery but a lens-based approach. But if the patient had a good DLI, a low PNS, and no normal internal aberrations, then that's when they were subjected to the non-strabismus binocular vision assessment and orthoptics evaluation. 5 patients had early lens changes, so they underwent cataract surgery. Non-strabismus binocular vision anomaly was done for 35 patients. A detailed orthoptic evaluation was done to rule out convergence insufficiency, accommodative excess or insufficiency, divergence insufficiency or convergence excess with the routine tests which are known for this conditions. What we found was that in our cohort, 14 patients had convergence insufficiency, 6 had fusional vergence dysfunction, 12 had accommodative insufficiency, and 3 had accommodative excess, and they were treated for the same. They were treated with a box string, the lifesaver card, the minus lens therapy, VTS4 computer orthoptics, and the accommodative flipper test. So these are the few examples. Here the quantity of vision is good, but the quality is poor. When we did the orthoptic evaluation, the impression was true convergence insufficiency, and this is how the point spread function looked like. The cornea is quite decent. There are not much aberrations present on the cornea, but everything is coming from due to the convergence insufficiency. When they were given the post-orthoptic exercises, their quality of vision significantly improved. So patients presenting with post-refractive surgery complaints like glare, halos, difficulty in focusing, headache, and other asthenopic symptoms, they pose a challenge to the refractive clinicians because they are unhappy and they make us unhappy. So significant number of patients may present with decentered ablation, dry eye, early lens changes, which may need appropriate treatment. A proportion of this can be attributed to the accommodative dysfunctions and the other non-strabismus binocular vision anomalies. So to conclude, even after orthoptic evaluation is within normal limit, it's abnormal, you give orthoptic exercises office and home based. But if it's normal, that means the patient has true regression, and that's when the recorrection is planned. So we knew that dry eye, decentered ablation, and lens changes are common causes of patient dissatisfaction, and post LVC and asthenopia can occur due to orthoptic anomalies. And if we treat these patients in the algorithmic approach, patients can have a good outcome. Thank you. Sorry for my voice.
Pooja, have
Yes,
you tried giving plano lens to the patient
we give
where
a,
dryness was not an issue?
no, sir, we give a contact lens trial to see if the quality of vision improves, but not a plano lens. We don't give those lenses.
Plano means plano contact lenses.
Plano, yes, that we have done. That we have done. If the contact lens, with the contact lenses, the vision improved, that means it's coming from the cornea. That's when we did a right away recorrection or a zone enlargement or a zone correction if the patient needed. If the vision did not improve with contact lenses, that means it's coming from lens or any orthoptic related issue. So that's when we went ahead with this.
Thank you.
Thank you, thank you.
We have now Dr. Siddharth Duggal. He will be presenting his paper on evaluation of different incision depths for capsulotomy in intermittent cataracts undergoing flax.
Thank you, sir. Good afternoon, everyone. I'm grateful to my mentors, Dr. Sheetal and Dr. Sri Ganesh, for this opportunity. So as we all know, an intermittent cataract is characterized by increase in the volume of the lens and also the presence of a layer of liquid lens mass, increased intralenticular pressure and thickness, decreased AC depth and the absence of a pink reflex, and all these factors are what make capsular access in these cataracts very challenging. The structural causes of these tensile weakness of the capsule is also seen on ultrastructural analysis. Femtolaser assisted cataract surgery has improved the safety because of the capsulotomy becoming more predictable, regular and well-centered, reducing the incidence of the Argentinian flag sign, capsule runoff and PCRs. However, capsular tags, capsular adhesions, incomplete capsulotomies requiring additional interventions are still there, and they increase the risk of capsulotomy extensions. In our study, we included patients having 2 or more of these criteria on AIOC2022 seen on MS39 topographer, anterior chamber depth of less than 2.5 millimeters, trabecular iris angle of less than or equal to 22 degrees, angle opening distance of less than equal to 290 microns, or a lens thickness greater than 4.5 millimeter with fluid pockets. As can be seen in this intraoperative picture of the OCT showing the fluid kefs as well as the intumescent lens and the fluid pockets. So the purpose of the study was to compare the safety, efficacy and feasibility of 1000 microns versus the 400 microns incision depth for capsulotomy in these eyes undergoing femtolaser assisted cataract surgery for intumescent cataracts. It was a prospective, interventional, randomized and comparative study and included 50 eyes of 50 patients diagnosed with intumescent cataracts. 2 groups were created, group 1 and group 2, wherein 400 microns and 1000 micron incision depth for capsulotomy was used, and the intraoperative OCT was used to assess the completeness of capsulotomy as free-floating nature or the presence of capsular adhesions, if any. And at 3 months, endothelial cell density was compared between the groups. In group 1, as can be seen, the incision depth was 400 and the horizontal spot spacing, the vertical spot spacing and the pulse energy was kept the same in both the groups. The total energy was slightly higher in the 1000 micron incision group. This is basic, the femto part of the procedure which is being done, and the incision depth has been changed to 1000 microns. The horizontal spot spacing of 5, vertical spot spacing of 15 microns has been kept for this patient as well as in the other group. The routine docking is done with after locking in position, the femto laser energy is fired, uh, and after that the cataract procedure is done. As can be seen in the 400 micron incision group, there were chances of rhexis runoff as can be seen in the above video, and which leads to anterior capsular rupture as can be seen. In the lower picture, we can see the side-by-side intraoperative OCT showing the capsular adhesions as well as bridges along with tissue tags, which were common in these patients which underwent femtolaser assisted cataract surgery. Also, there were chances of incomplete separation of capsulotomy, which may require additional manipulation and further increases the chances of anterior capsular rupture. However, it should be noted that not all cases can be converted to 1000 micron incision depth, as sometimes an error showing such as this can be seen. In one of the cases where the capsulotomy was seen to intersect the lens posterior, and they asked us to verify the surface fits, and so we had to continue with the 400 micron incision only. Preoperatively, the endothelial cell density, the age, which was around 65 years, the best corrected visual acuity and intraocular pressure did not vary significantly between the groups. Intraoperatively, in the 400 micron incision group, while there were free-floating capsulotomy seen 1000 micron incision group, it was seen in 81% of the patients, which means that only with viscoelastic the capsulotomy could be removed. However, it should be noted that still 4%, that is one patient, had adhesions 0 to 4 clock hours even in 1000 micron incision group. Intraoperatively, none of the patients had a PCR. However, capsular excess runoff was seen in 3 patients in the 400 micron incision group. But even one patient in the 1000 micron incision group also had capsular excess runoff. This is a case where the capsulotomy was performed with the help of a 1000 micron incision group after staining with trypan blue dye, and only with the help of viscoelastic we were able to remove the capsulotomy without the need of any further interventions. And at the end of the procedure, we can see a clean cut capsulotomy without any ragged margins. Postoperatively, clinically there was no increased inflammation in the 1000 micron incision group compared to the 400 at 1 week and at day 1 postoperatively. At 3 months, the endothelial cell density was 2501.44 in the 400 micron incision group and 2430 in the 1000 micron incision group, and the values did not differ significantly. The uncorrected visual acuity, intraocular pressure, spherical equivalent, and the best corrected visual acuity were also comparable and did not differ significantly. As we all know, once the eye is docked, there can be an anterior shift of the capsule and the lens, because after docking there's under suction pressure, and the plane where the capsulotomy has to come shifts. In intumescent cataract, as we know, there is fluid inside, and there's much more likely shift, and insufficient energy may be there, leading to tags. So the femtocapsular excess, when done, should be done with caution due to the release of the fluidized lens material into the AC after opening of the anterior capsule. And the movement of the capsular leaf under the current focus of the laser towards the uncut areas may be there, as has been noted in previous studies, and the displacement has been seen to be around 150 microns. So to conclude, capsulotomy using 1000 micron incision group does offer advantages. However, it should be done with caution in these challenging cases.
Yeah, so why did you increase it to 1000? Why not just 800? Because 1000 is quite a bit.
No, ma'am. There have been previous studies also who have done the same, and we wanted to compare with those studies, and increasing it to 1000, if we could increase it to even slightly more, maybe 800 microns would have also been an option, but we wanted a clear-cut distinction between a 400 and a 1000 micron incision depth, and the results showed us the same.
Okay.
Thank you.
We have now Dr. Sharon D'Souza. She is going to present on effect of capsule cap depth in SMILE on clinical, biomechanical and molecular outcomes.
Good afternoon, everyone. A big thank you to the respective judges and the organizer of AIOS for including our work in this pre-paper session. So I'll be talking about how the cap depth in SMILE could have an effect on the clinical molecular outcomes. I have no financial interest in the subject matter of this paper. So a lot of this paper hinges on how the SMILE or any corneal-based refractive procedure has an effect on the nerves. We know that the nerves can be transected or be damaged during a refractive surgery. And these nerves are very important for the sensory and reflex function. They can lead to some amount of inflammation, and they have a trophic effect with the epithelium. So even though in SMILE we do know that compared to a LASIK there may be less amount of nerve transection, in spite of that, it has been shown that during the SMILE, the nerve fibers which are intersecting in the lenticule cap plane can be transected by the femtosecond laser, and therefore there is some amount of degeneration. Now it remains to be seen whether this has a clinical impact, and that is what we were trying to study in our paper. The corneal re-innovation post any refractive surgery, we know that thankfully in a SMILE surgery the re-innovation is higher compared to other refractive surgical modalities, and this has been shown multiple times over various papers. Now what we are trying to see, and these diagrams just show that in spite of the fact that the SMILE cap does transect less nerves, it does have an effect in, because it is in the mid-stromal plane, the cap lenticle which has been removed. So can we achieve, by altering the cap depth, can we achieve a better corneal nerve preservation and regeneration? And is this required clinically? So does this really change how the eye heals after the surgery? So our knowledge gap is to try and see whether, there are enough studies to show that the cap depth can be done across, caps can be done across different depths, including 100, 120 or 150 microns, and does it really matter in our clinical judgment? So this was our research question, that whether once there is a nerve transaction, does the regeneration happen faster, and does this result in a better ocular surface health? So the patients undergoing SMILE who had a symmetric refractive error, because this is a contralateral eye study, between 20 to 30 years were included. And we excluded, of course, the routine exclusion criteria for various refractive surgeries like an abnormal topography or an ectatic eye, severe dry eye, any active infection, or a prior surgery. And there were 80 eyes included in this procedure. And as I specified, it was a contralateral eye study in which one eye had a cap depth of 100 and the other had a cap depth of 150. These were the tests which we did in the preoperative clinical workup, which was similar for both the eyes, in which we basically looked at how their topography was, how their refractive error is, optical quality pre and post, the dry eye, because that intuitively we would think that there may be a difference, and the various molecular factors, and this was followed up at 1, 3, and 6 months. So all the surgeries were performed by a single surgeon on the Visumax platform. Similar cap diameter for all, energy settings and laser parameters were similar across all the eyes. So these were the outcome parameters that we studied, which was, as I said, the visual acuity, the optical quality, because not only are we looking at the quantity of vision, we also look at the optical quality. And this was done by the OCAs. And we also looked at how the nerves were regenerating, and to see whether this actually had an impact on the epithelium regeneration, we looked at the epithelial map. The in vivo confocal microscopy can study various factors of the subbasal nerve plexus, and these were followed up in these patients. To see if there was any dry eye worsening, we checked the Schirmer's T-Butt staining, and of course the molecular factors, which were analyzed by our tear fluid analysis. Coming to our results. In the initial period, at 1 month, the patients who had the eyes which had a deeper cap had less reduction in Schirmer's. However, no patient developed any severe form of dry eye even at the early post-operative period. Similarly, even the tear breakup time had a lesser reduction in the 150 micron group. However, this did not hold true once the patients went into the longer follow-up, and at the long follow-up at 6 months, there was no difference between the two groups, that is the 100 micron and 150 micron. There was absolutely no difference in their dry eye parameters. Again, there was no significant difference between the outcomes, that is the visual, optical outcomes, or the epithelial thickness outcomes, or their healing, between the 100 micron and 150 micron group, which is very reassuring. The change we did see was in the nerve density. So even though both caps did have a transection of the nerves, there was less reduction in the corneal nerve fiber density in the 150 micron cap. Also, the regeneration of the nerves was much faster in the deeper cap, that is the 150 micron cap. So by 1 month itself, you can see in the 150 micron, the nerves are regenerating, and by 3 months and 6 months, they almost look normal. What remains to be seen is whether this has a clinical relevance to it, because as I was saying, there is no change in their dry eye parameters or the epithelial healing or their visual outcomes. Even across the molecular factors, there was no difference observed between the two cap depths over the post-operative period. The anti-inflammatory, certain cytokines did show an increase in the 150 micron depth, but since this was an isolated single factor, it cannot be given that much value. But what is interesting is that in the deeper cap, as we intuitively would agree, I'll just close, the ECM modulators did show a change. So why is this very important? So because there is a faster recovery of the subnasal nerve plexus in the 150 microns, we would expect that there may be a clinical relevance, but over time, this has not shown in our clinical parameters, and the regeneration at 6 months was comparable. So what we see is that the subbasal plexus reached a very quick recovery, but at 6 months there was no difference between the two. So in a clinical practice, this would not matter. Of course, if you have a patient who already has a pre-existing ocular surface issue, we may want to take a deeper cap to help the healing faster. Thank you for a patient listening.
Excellent presentation, Sharon. Now, probably this study must have given you an idea for another topic to check the biomechanical strength of these corneas post-operatively,
Yes, sir. So we've
because
also
that
looked
gives
at
you a
that.
difference again.
Absolutely,
Yes.
absolutely.
So probably next year you'll come up with that presentation.
Absolutely. We looked at it for a part of them. There was not much difference again, which is expected. Very interesting because we're cutting deeper.
Was there any correlation with pre-existing like refractive error with higher the?
No, again, we also thought that they may be, that the higher power ones may have more changes, but surprisingly no. Initially, maybe a slight change, nothing significant, but by 3-6 months, no difference at all.
Means why should it bother actually?
If a thicker lenticule extraction, maybe more nerve damage, something like that. But it didn't have. Thank you.
We have now Dr. Reshma Ranade. She is going to talk about her paper regarding artificial intelligence and simulation-driven pathfinder in refractive surgery.
Good afternoon, everyone. I'm here to talk on AI and simulation-driven pathfinder in refractive surgery. At the onset, none of the authors have any financial interest in the subject matter of the study. Just a minute. So prediction is certainly the future of medicine, and where prediction has found its way in every other field, why should refractive surgery be an exception to this? Currently, the decision-making in refractive surgery is essentially based upon topography-based indices as well as biomechanics, and also some amount of the risk-scoring systems play a role. But we still need parameters to predict post-operative outcomes and the strength, and to make decisions regarding whether we can operate a particular patient or not. These are a set of confusing case scenarios wherein they have different permutations of CBI, TBI, as well as the topographic parameters. And is there a way here where we can choose a right refractive surgery procedure for such case scenarios? Can we predict the outcomes of refractive surgery in these cases? To understand this, we should first know what is finite element method. So it's a numerical technique which divides a larger complex system into smaller, simpler parts called as finite elements. So it finds a wide applications in aeronautical, automotive and biomechanical industries. So we thought, why not apply this to refractive surgery as well? So we created a finite element model of the cornea, and this in combination with the topography and the biomechanics was incorporated into our application called the AIOC2022. So in order to generate a prediction model, what we need is a machine-specific ablation profile, and this in combination with the finite element model helps us to generate a forward FEM model in order to get a post-operative deformation curve which would predict the post-operative corneal stiffness. We virtually simulated 3 refractive surgeries, the LASIK, SMILE and the PRK, and the predicted stiffness which matched the post-operative patient corneal stiffness. The predictive modeling can be used to predict the outcomes of the surgery accurately. This was a previous paper wherein we have used artificial intelligence in order to pick up stable versus progressors in keratoconich eyes. And this brings us to our research question: can we have a simple software of FEM modeling and artificial intelligence which can be used for every patient to screen and also predict the outcomes? So we incorporated tomography, biomechanics, finite FEM model of the cornea, and artificial intelligence to create AIOC2022, the pathfinder for refractive surgery. So how does it work? In order to run the data, we first import the tomography and the biomechanics in the form of a comma-separated value, or the CSV file, following which we choose the surgery to simulate, and the flap and the cap thickness and the optical zone needs to be entered. The patient's refraction is then entered, and the add to run Q tab is then pressed. So once the report is obtained, we can export it in the form of a PDF. Now, can we use the simulation tool to predict the percentage of biomechanical weakening after refractive surgery? So this is what the refractive surgery simulation report looks like. So the orange curve represents the preoperative stiffness, the green represents the predicted postoperative stiffness, and the blue bell-shaped curve tells you about the change in the stiffness. In addition to these reports, you also get the ectasia risk assessment report, wherein it classifies the cornea to have either a normal stiffness post-operatively or moderate risk or high risk. So can we use the simulation tool to choose the type of refractive surgery? Definitely yes. Based upon what is the predicted post-operative corneal stiffness, we can determine which of the procedures can be a safe bet. So here is a case example wherein we see that the change after SMILE, LASIK and PRK is almost equivalent, and which shows that such corneas would tolerate either of the procedures well. So we studied a total of 1529 eyes consisting of 900 LASIK, 360 eyes with SMILE and 240 eyes with PRK. And in addition to the clinical examination, these patients also underwent a pentacam and the biomechanical data. And then the software was run after these scans were imported. And then we did the post-operative validation by a follow-up. Coming to the results, the AI build-up using 1529 eyes was collected across multiple centers across the world, and it helped in successfully predicting post-operative biomechanics of 12 ectasia eyes. In addition to this, as we spoke about this earlier, it also gives you an algorithm wherein it helps you to pick up the right procedure for the patient based upon the risk that the nomogram gives. So we have known that the post-operative excessive biomechanical weakening can lead to ectasia in normal eye, and currently there is no tool to predict the post-operative outcomes. This is the first AI-based simulation software for refractive surgery in the world in order to predict the post-operative weakness, and it's also the first software to include India-specific data. This software is in beta testing phase at 20 centers across the globe. Our next step is to integrate AIOC2022 into other existing topographers as well. Thank you.
Thank you, Reshma. Now the only question remains is, what is the exact AI doing in these things?
So sir, primarily this
because do you mean to say whatever cases of post-LASIK ectasia or you have predicted earlier in those cases, those parameters or those pentacam reports or this biomechanic Corvis reports were normal, and still with the help of AI you could pick up?
So sir, the 12 ectasia eyes that we had, these were the patients wherein we had pre-operative as well as the post-operative data. So our longest follow-up was of 38 months, wherein we picked up that these 12 patients had ectasia. And this AIOC2022 is primarily a simulation tool, and it secondarily uses AI. So AI is not the primary factor in the AIOC2022. The primary factor is the FEM model and the simulation tool. And secondarily, the AI just helps in predicting the biomechanical stiffness after the surgery.
Okay. The same principle which pentacam currently is using in topography,
Yes,
you
sir.
have integrated multiple parameters into it.
Yes, sir.
Thank you.
Thank you, sir.
I think you have another topic also. You can continue with that thing.
Good afternoon, eminent panelists and my colleagues here. Today I'll be presenting on how all post-refractive surgery corneal microstructures are not the same. Let's have a look at the normal case with a normal topography and epithelial mapping pre- and post-operatively. But it raises an interesting question. Can normal-looking topographies always have the similar outcomes? Here are some cases we have picked up some normal topographies pre-operatively, but post-LASIK surgery outcomes were variable. If we see the first case, we can see a happy patient with 6x6 vision. The second case had good vision, but complained of glare and asthenopic symptoms. The third case showed diminution of vision with uncorrected visual acuity of 6/18 parts. And the fourth case showed high astigmatism with thinning of the cornea on the topography. So 4 normal cases, but why different outcomes? Currently, the treatment is based on the corneal topography, epithelial mapping, biomechanics, and aberrometry, which do not fulfill our answer completely. So is there a need to look deeper? That's because these current mode of diagnostics help assess the surface changes. But can we understand the outcomes at the ultrastructural level? Probably yes. Polarization-sensitive optical coherence tomography does in vivo collagen imaging. PSOCT projects polarized light over the cornea and measures the way the polarization state of light is altered. We can quantify the corneal collagen distribution using in vivo non-touch techniques. This is how the corneal birefringence depends on collagen fibril orientation. The custom-built PSOCT was started at our institute in June 2019, and since then we have been doing the collagen imaging to understand the cornea better. The purpose of a study was to assess the distribution of collagen in corneal stroma pre- and post-operatively in post-laser surgery eyes with PSOCT. A retrospective observational study of 25 post-LASIK patients were done with the standard inclusion and exclusion criteria for the LASIK patients. Clinical evaluation, diagnostics which included corneal topography, biomechanics, epithelial mapping, and PSOCTs were done pre-operatively, and follow-ups were done at 1, 3, and 6 months. So our research questions were, can we compare the collagen structure post-LASIK surgery? We can now see the changes in the collagen structure of pre- and post-LASIK eye. Different types of laser surgeries are going to affect the interlamellar fibers of the stroma in different ways. Hence, the remodeling and the healing process is going to be different and unique for every eye. Few of the post-LASIK cases are shown here at different time points, showing how the retardation maps are similar to a normal virgin eye or close to a normal virgin eye, wherein the retardation is least in the center and increased in regular manner towards the periphery. This shows how few eyes have stronger signals and few do not. So, will this help understand the cause of post-LASIK ectasia? Let's have a look for two cases, one was 7 years post-LASIK and second was 5 years post-LASIK. The first case showed normal topography, epithelium and collagen, and the second one showed thinning of cornea, irregular epithelium and abnormal collagen in the second case. Suspicious corneas revealed a unique distribution of collagen, indicating early changes even before the corneal the topography and the clinical manifestations. Few post-LASIK ectatic cases are shown here at different time points again, showing the partial and complete loss of anchoring fibrils, showing the loss of the rhombus pattern or what we call the checkered pattern. Then the question arises, are all thin corneas always abnormal in that case? The scan shows the thin corneas but no keratoconus or no suspicious corneas with poor collagen and low SPA1. But if you look at the Bowman's layer is thick, which might be the reason to slow down or retard the progression towards ectasia. So all thinner corneas not necessarily progress to ectasia. Few of the insights are, post-LASIK healthy eyes had retardation maps similar to a normal virgin eye, wherein the retardation was least in the center and increased in a regular manner towards the periphery. Every post-LASIK eye is different. The retardation maps of an post-LASIK ectasia were found to be similar to those of the keratoconic eyes, showing higher retardation in the center as compared to a healthy eye. Not all thinner corneas progress to ectasia. So what was known earlier was PSOCT differentiates healthy and ectatic corneas with strongly bound in normal than the keratoconic eyes. It can become an integral part of screening of ectatic and preoperative workup of refractive surgery patients. It is one of the reliable techniques to study and observe the corneal wound healing process postoperatively. What does our study add? Each refractive surgery will affect the stroma in different way, hence cannot be compared. Suspicious corneas reveal a unique distribution of collagen, indicating early changes before the topographic manifestations in these eyes. And all thin corneas do not progress to ectasia. Thank you.
Thank you, Saidi.
Thank you, sir.
So next is Dr. Nilesh Kumar. Is he there?
To all the judges. Good afternoon to all the judges and everyone in the audience. First of all, I would like to thank AIOC Scientific Committee for providing me this opportunity. I am Dr. Nilesh Kumar, and I am here to present my work, Evaluation of Angle Kappa in Patient Undergoing a Smile for Myopia. So SMILE has proven to have better corneal biomechanics, predictability, and improved visual outcomes and faster recovery times. So coming to angle kappa, that is the angulation between the visual axis and the pupillary axis. which is defined in terms of distance or degrees and has become one of the most important parameters being discussed in refractive surgery right now. It has been shown to alter the outcomes based on centration of the ablative zone, but any effect on or due to SMILE has not been studied till now. Orbscan 2Z, which combines scanning slit lamp imaging with placido disc to perform corneal tomography, measures the angle kappa by centering the pupil and the optical axis, and the resolution corresponds to 0.01 mm. In general population study done by Hashmi et al., the mean angle kappa was 5.46, which was affected by refractive error and age, and the mean angle was 5.13 degrees in myopia and 5.72 degrees in emetropia. So most debate around the angle kappa is to choose the centration. Should it be on the optical axis or the pupillary axis in order to optimize the outcome? But SMILE itself by design is always centered on the pupillary axis because of the suction cup. So the study by Zairi et al. Evaluating the changes in angle kappa following PRK found no significant change, but that was on optical axis, not on the pupillary axis. So the research question in hand was, does any change occur in angle kappa in the eyes undergoing SMILE for correction of myopia, and is such there any correlation between these changes and the preoperative parameters? So it was a prospective single center interventional study conducted from January 2019 to December 2019 at a tertiary level hospital. At 95% power of the study, it was 225 eyes to be evaluated. The ethical committee clearance was approved, and all the ethical committee, all the parameter were there to Declaration of Helsinki. More than 22 years of age with refractive error up to 10 diopters of myopia, stable 1 year preoperative refraction with BCVA of 0.0, and the central corneal thickness more than 480 was the inclusion criteria. The topography was performed by single operator, and the single surgeon performed the SMILE using regular parameters. So at 3 months, the changes in angle kappa, keratometric indices, pachymetry, and lenticule thickness were analyzed using IBM SPSS version 25. The normalcy of data was used with ANOVA, and paired t-test was used to compare the changes between preoperative and post-operative value. Pearson correlation was also being calculated with significance of less than 0.05. The preoperative UCVA improved from 1.23 logmar units to 0.26, while the MRSC improved from minus 4.73 diopter to minus 0.31 diopter of myopia. So in 131 eyes, the angle kappa increased significantly from 4.75 degrees to 5.24 degrees, while it decreased significantly in 171 eyes from 5.02 to 4.52 degrees. The increase in angle kappa had a significant negative correlation with pachymetry and with the lenticule thickness, while decrease was positively correlated with the pachymetry readings. So we did a post hoc regression analysis with these parameters, and we found that there is a linear correlation. Wherever the angle kappa changes, there was a linear correlation with pachymetry, lenticule thickness, and the simulated K value. So Orbscan 2Z, which utilizes the placido disc in conjunction with scanning slit-based topography, has been proven to estimate the angle kappa slightly higher than synaptophore, but Orbscan itself in itself is a reliable machine, and the values cannot be used interchangeably with synaptophore. So Zairi et al. Have demonstrated that there is no change in PRK. The centration, though was done on optical center, different from SMILE. The study demonstrated the angle kappa increased significantly in 131 eyes and decreased in 117 eyes. The increase in angle kappa, as told, was negatively correlated with lenticule thickness, while decrease was positively correlated with pachymetry. This could be interpreted as a thin lenticule can increase the angle kappa, while a thinner cornea preoperative, when corrected with SMILE, can decrease the angle kappa. So basically, a thicker cornea, if we are having after the SMILE surgery, it is increasing the angle kappa, and if the cornea is thinner post-operatively, the angle kappa is decreasing. It is very early to comment upon the effect of such change that can have on future outcome, mostly when we are going to implant premier intraocular lenses in the patients who have already undergone SMILE and have change in angle kappa. So the changes in keratometric values post LVC, as we know that K1, K2 changes post LVC, and then it has an aberrant effect. It becomes the IOL power calculation becomes cumbersome and unpredictable. So we don't we don't yet know that angle kappa is having any effect, any such effect in future. The present study is not in a position to comment on any such changes. It though appears worth exploring the causal relationship in view of choosing the procedure of choice, that should we use smile in all patients, or do we have to change it depending on angle kappa and their pachymetry value, and the long-term effect of such changes in future procedures. So the limitation of study is the shorter duration of follow-up, which is insufficient to predict the changes, and the pilot study was not powered enough to do a post-hoc analysis. Thank you so much.
Thank you. Anaga, you do smile? No. Anybody in the audience? Sharon is there? Sharon, I have question. Whatever he has explained, how angle kappa is significant in treating myopia specifically? I can understand a situation of hyperopia, but how is there any special indication whereby you should say study angle kappa while treating the myopia in smile?
For whatever reason. Yes.
It was.
So,
Did you
yes, sir.
find any reason why this should get?
Yes, sir. We found out a few patients who were coming post-refractive surgery undergoing smile. They not undergoing smile, but they had undergone LASIK at our center 10 years prior, and now they came for cataract surgery, and we used to find that they are not satisfied with the outcomes of premium IOL.
But they underwent surgery for myopia only.
Myopia only, yes, sir. So it was like our center now was moving on to smile, so we wanted to study like should we take any precaution in choosing our patient to go for PRK, because PRK is not giving any such change in angle kappa. So that was the research question we had.
Basically, ablation would be the same. So why should it differ between
Can you
LASIK or
explain
PRK?
this, Sharon?
Yeah. Would be the same.
Yeah, ma'am. But the study was done on PRK, so I can't comment on LASIK, ma'am. Yeah. So the study which I found was only on PRK. LASIK, they have not, because most of the studies on this topic, angle kappa, is basically where we are getting the better outcome. Is it while centering on the optical zone or pupillary axis? But the change itself was
How
not.
did you
First
measure
thing I
angle
didn't
kappa?
understand. Sorry.
Sorry. Yes, sir. What did you use to measure the kappa, angle kappa?
Ma'am, it was done with Orbiscan, ma'am. Orbiscan 2.
Scan 2. Now, but how will you signify that angle kappa was responsible? What was the pre-op angle kappa in those patients who got treated for myopia?
Yes, sir. The pre-op data was. That's what we wanted to find out. Is there should we study this more? That was the pilot
Because
study.
you
we
are
wanted
just
to do.
different in PRK and this thing.
Yes.
So we don't have the details which were earlier.
Yes, sir. Yes, sir.
So without that, I think we cannot come to a conclusion.
Thank you.
Thank you, sir.
Reshma, are you ready?
Good afternoon, everyone. I'm here to talk on an algorithmic approach to manage post-refractive surgery, glare, and asthenopia. To begin with an increasing demand in the refractive surgery, we have patients with increasing expectations with respect to the quality and the quantity of vision, good night driving, visual clarity, and excellent depth of focus. But is that always the reality? We do have our share of unhappy patients who present to us with glare, halos, blurring of vision, and asthenopia. So why do our patients develop glare after refractive surgery? So this is to understand the optical system. We have the glare source angle and the refracted angle and the reflected glare image which is formed similarly at the retina. Recent studies have, of which one of which is our work, has shown and proven the role of binocular single vision assessment in refractive surgery workup. This brings us to our research question: can non-strabismic binocular single visual anomalies be responsible for glare and asthenopia after refractive surgery? So we studied a total of 4,000 refractive surgeries, of which 28 patients presented with glare and asthenopia. After a detailed history and the visual assessment, we did a dry eye workup, and then the patients were imaged on the pentacam in order to identify if it is a centered or a decentered ablation, and then the aberration profile was seen. The patients were subjected to contact lens trial, and lenticular changes, if any, were identified on the DLI and the PNS. If at all these parameters were normal and there were no lenticular changes, we then subjected these patients to a non-strabismic binocular single vision assessment. These are a set of direct and indirect tests that are practiced for convergence insufficiency, accommodation excess, accommodation insufficiency, divergence insufficiency, and convergence excess. We found that all those 28 patients had some or the other NSBVA issue, of which the most common was convergence insufficiency, followed by accommodative insufficiency, fusional divergence dysfunction, and accommodative excess. After the orthoptics evaluation, when it was found to be abnormal, we found that it was either hyperopic shift, myopic shift, or glare. And 26 of these patients improved, and 2 of them had to undergo a laser recorrection surgery. These are the vision therapy exercises that we practice at our institute. We have the vectogram, the lifesaver card, the minus lens therapy. The patients presenting to us with post-refractive surgery may complain with glare, halos, difficulty in focusing, headache, and other asthenopic symptoms, and they are a challenge to the clinician. Some of these patients may be attributed to dry eye and decentered ablation, but majority of these can be attributed to accommodative dysfunction and other non-strabismic binocular single vision anomalies. To conclude, visual complaints of glare and halos post-refractive surgery should be evaluated by a complete binocular vision and orthoptics assessment, and it should also form an essential part of our workup in the as a part of the pre-operative workup. What the study adds is that in an era of increased screen time, particularly also in the COVID time, patients are at a higher risk of NSBVA-related anomalies. In spite of a perfect surgery, post-surgery, the patient can still be unhappy because of these issues, and orthoptic evaluation should be an important component. In our study, we found that the NSBVA correction did not only reduce the need for the unwanted recorrections, but it also increased the patient satisfaction. Thank you for patient listening.
Thank you, Reshma.
Thank you, sir.
Next is Dr. Sneha.
Brij Kishore Gupta, a novel decision tree with biomechanics in refractive surgery.
Good afternoon, everyone. I will be presenting on a novel decision tree with biomechanics and refractive surgery, and I have no financial disclosures. So the evolution of diagnostic modalities in refractive surgery has been a boon in picking the right choice and avoiding complications. Currently, the decision is majorly dependent on the basis of corneal tomography and biomechanics. So here are a few case scenarios in our refractive clinic. The first one showing a normal topography and a normal biomechanics, an ideal case to go ahead with refractive surgery, and the second one showing keratoconus, which is an absolute contraindication. Here are a few more case scenarios that may present to us. The first one with a normal tomography, but an abnormal biomechanics and abnormal TBI, and the second one with a normal topography, borderline bad D, normal biomechanics and abnormal TBI. What do we do in such case scenarios, and how do we proceed further? So which parameter should we give more weightage to? Should it be a corneal topography, which is an indirect measurement of corneal structure, or biomechanics, which is an indirect measurement of strength? We stumbled upon an article which studied the role of biomechanics for evaluation of ectasia in patients, and we found that TBI had showed a better performance with all the other individual parameters, concluding that integration of biomechanics with tomography augments accuracy for detecting ectatic disease. And biomechanics is an essential tool in this screening process. We lacked a systemic approach in the existing literature to plan the refractive surgeries in various case scenarios. So this brought us to our research question of how do we make this confusion matrix more understandable to the clinicians. So the purpose of our study was to plan an algorithmic approach to plan refractive surgeries on the basis of tomography and biomechanics, and to optimize visual, tomographic, biomechanical outcomes after the surgery. We carried out a study where we recruited 345 eyes of 175 patients after the ethics committee approval. Informed consent was obtained. Patients motivated for surgery with no corneal scarring, ACD more than 2.8 and RSB more than 270 were included. The ones with active ocular surface allergy, corneal scarring, pregnancy, lactating mothers and prior ocular surgery were excluded. It was a prospective interventional study where extensive clinical evaluation with diagnostics was performed. Patients were categorized into 4 groups and then the refractive surgery was planned accordingly. They were evaluated at 1, 3, 6 months post-operatively, 1 year and 3 years post-operatively. So the 4 groups into which they were divided were, the first one having a normal tomography and biomechanics included 100 eyes. The second one with a normal tomography and BAD-D, a borderline biomechanics and CBI and a borderline TBI. The third one having 80 eyes with borderline topography and BAD-D, normal biomechanics and CBI and a borderline TBI. And the third one having all the indices abnormal included 65 eyes. Now applying the algorithm in our clinics, the first group was planned for LASIK, SMILE or PRK depending upon the examination, diagnostic reports, patients and the surgeon's preference. The second one, we further checked the parameters like biomechanical corrected IOP, stiffness parameter and the scan quality. The ones with a normal BIOP or along with stiffness parameter less than 100 were planned for phakic IOL. The ones with normal BIOP and stiffness parameter more than 100 were planned for SMILE extra or PRK. The ones with a low BIOP and low SPA1 and good scan quality were planned either for a phakic IOL or PRK depending upon the spherical equivalent. The poor scan quality patients were re-evaluated and then planned. The patients with having a borderline topography with normal biomechanics, a good quality scan, the epithelium was checked. The one with normal epithelium were planned either for a phakic IOL or trans-PRK. The ones with abnormal epithelium were treated for ocular surface inflammation as the borderline BAD-D was considered was correlated with this abnormal epithelium and then were planned for LASIK or SMILE after 6 months. The ones with poor scan quality and abnormal angle kappa were re-evaluated and then planned for the surgery. Those patients with an abnormal topography and abnormal biomechanics were planned for phakic IOL implantation. So this graph shows the distribution of patients undergoing the type of refractive surgery in each group. And this is the efficacy where the post-operative uncorrected visual acuity was more than 20 by 25 in 98% of the patients in group 1, 99 in group 2, 96 in group 3 and 95 in group 4. There was no loss of lines in group 2, 3 and 4 and 1% of patients showed loss of 1 line in group 1. One case out of 345 eyes developed ectasia after 3 years. So our algorithm is safe and effective in all 4 groups. The algorithm is accurate in classification of patients according to their tomography and biomechanical characteristics and is in accordance with the previous literature where CBI and TBI showed good correlation to the predictive postoperative outcome. It is prudent to avoid SMILE and LASIK in suspect eyes and better to go for extra procedures. The patient that developed ectasia had a normal tomography and biomechanics. Lenticular analysis showed decreased expression of LOX and collagen, and this decreased pre-existing levels of LOX and collagen may predispose clinically healthy eyes undergoing refractive surgery to develop ectasia post-operatively. So pre-op molecular testing may reveal ectasia susceptibility in absence of tomographic and biomechanical risk factors. So what was known is corneal biomechanics is an important tool for pre-op assessment and it is relevant for a proper follow-up of post-laser vision correction patients. It helps in early diagnosis of patients with high risk to develop iatrogenic ectasia. What the study adds is, it is the first study that proves efficacy and safety of an effective and simple algorithmic approach to plan refractive surgery. It augments accuracy for integration of biomechanics and tomography, augments the accuracy to detect ectasia and also identify susceptibility to ectasia. Addition of CBI and TBI in the algorithm makes it more robust in diagnosis of suspicious cases. Thank you for patient listening.
Thank you. I think that should conclude the session now.